Welcome back to Season 3 of School of Speech, presented by Speech Therapy PD. I'm your host, Carolyn Dolby, and today's episode is your OMD Survivor's Guide for the School-Based SLP. I'm joined by veteran clinician and author of the Miss Tongue and Friends book series, Tricia Rogers. Together, we're going to define orofacial myofunctional disorders, or OMDs, highlight their common characteristics, and break down the fundamentals that set OMD treatment apart from traditional oromotor exercises. We'll also be exploring resources to support assessment and therapy. So this conversation will equip you with clarity, confidence, and the next steps for addressing OMDs in your school setting. And don't forget, you can earn 0.1 ASHA-CEUs by completing the course modules on your Speech Therapy PD account. Now, let's get on with the show. Hello, everyone, and welcome to School of Speech, presented by Speech Therapy PD. I'm your host, Carolyn Dolby, and I am so glad you tuned in today. Today, we have my friend Tricia Rogers today, and this episode is OMD Survivor Guide for the School-Based SLP. Let me tell you a little bit about Tricia. She is an ASHA-certified speech-language pathologist with nearly 30 years of experience, and for more than 2 decades, she has specialized in orofacial myofunctional disorders. That is a mouthful, no pun intended. She's been working with children to improve breathing, oral rest posture, and overall oral function. Alongside that, she's running a private practice. She also mentors, presents, and consults with professionals nationwide. She's amazing. And I've already seen her present. It's amazing. She is a creator and the author of the Miss Tongue and Friends book series. It's a children's book series that is designed to make myofunctional concepts simple, fun, and engaging. These books are now being used by therapists, educators, and families as practical resources to support healthy oral development and lifelong habits. Through her Miss Tongue and Friends books, Tricia is bringing these important skills to children around the world in a way that feels playful, approachable, and empowering. All right. We all need to start settling in for another great episode with this amazing clinician. I do want to remind everyone that each episode of School of Speech is offered for 0.1 ASHA-CEUs. Just a little bit more of housekeeping. I'm just going to go through some quick disclosures. I think I mentioned Tricia is the creator and author of the Miss Tongue and Friends book series. And she may benefit financially for the sale of those materials. And non-financial, she is a member of the Dove Lewis Portland area canine therapy team with her certified therapy dog, Fala. And she also volunteers at the GG Playhouse. For me, I am a salaried employee at Portland Public Schools, and I do receive compensation from Speech Therapy PD for hosting School of Speech. Non-financial, I am a consultant for school districts to support their dysphagia development and staff training, and I also volunteer with Feeding Matters on their education committee. Okay, enough about me. Hey, Tricia Rogers, how are you?
Good. How are you?
I am great. Thank you so much for being here today. I first, y'all that listening, I first met Tricia in the summer back at the Speech Therapy PD Back to School Conference, where I was first introduced to her books that are phenomenal. And then we shared a great dinner. That is where we just totally clicked. And I was like, I have got to get you on this podcast. And I am so blessed that you agreed. And here we are today. I love it. And thank you, everyone jumping in from all over the place. Hi, everybody. We are so glad you're here. I know that we've got a lot of people listening, and we've got a lot to cover today. So let's get into it. I am definitely not trained in OMD, and I kind of want to start from the beginning. First, maybe I kind of gave your bio, but do you want to give us a little bit more of your journey, getting the party started that way, and then maybe we can get into like defining some definitions and stuff. But how did you get?
Yes.
How did
I get here?
Yeah. How are you?
Oh, I'm so happy to be here with you and have this more time with you. So I am originally from the South, and we moved out here in 1998. I live in Oregon now, and I did my undergrad and grad school in speech, and it was under the education and undergrad. So
Mhm.
I worked, did what do you call it? This student training in the schools.
Your
And then
externships.
yes, thank you. And my first year of working was in the schools in Greenville, South Carolina. And so that was super duper fun. So I loved that. And then when we moved away, I then was no longer in the schools when we moved to Oregon, but in Pennsylvania, I worked in an inclusive setting with kiddos at Head Start and Inclusive. And so that was a good experience. So I love working with kids. And I love collaborating now with speech pathologists that are in the schools and also presenting and mentoring. So my heart, the schools, connected with the schools. Yeah.
Yeah.
And private practice started off working for two other speech pathologists in town, and then off on my own when they went out. So yeah, it's been fun. I never expected to be in private practice, but I love it. I do. And I now love everything else I'm doing too.
I
Mhm.
always love finding out people's journeys because we are all speech language pathologists, but we all have a different journey to of
Yes,
kind of like how we got here, why we got here, and
yes,
it's just fascinating to me. So
yes,
thank you so much for sharing,
yes,
and I do know that you've also presented for an entire school district
yes,
some of
yes,
this material. So
right.
um,
Yes,
this is
yeah.
definitely for schools,
Mhm.
definitely.
It is.
How about starting with defining some
Okay.
lay some definitions on us. Start from
I'm
the
going to do
beginning.
that. So there are many, many definitions for oral facial myofunctional therapy or disorders, orofacial myofunctional disorders. And because it covers such a vast amount of information and symptoms and all of that. So I have one that I've kind of put together, and I got my cheat sheet here so I don't make sure I don't mess it up. But OMDs are habits, conditions, or atypical patterns, okay, that affect facial muscles and the mouth, which are the lips, the tongue, and the jaw, and how affect how the facial muscles and the mouth rest and function. And that's where it is. It affects how they rest and function, often affecting speech, breathing, desirable resting postures, chewing, swallowing, and speech production. So it's a lot. Foundationally, it's like issues with oral resting and oral function. And that's what OMD, that's a good definition of it.
I like that. Habits,
Habits.
conditions, or atypical patterns.
Patterns. Yes.
Yeah,
So
I
that kind
like
of
that.
covers it all,
Yeah.
like thumb sucking habits, conditions where it could be like a malocclusion or a
Hmm.
dental condition, right? And then atypical patterns like an atypical swallow or an atypical tongue rest posture. So that's why I like to say the habits, the conditions, and the patterns. And
Yeah. Thank
yeah.
you.
So it's the concept is, the oral facial myofunctional therapy is a mouthful, as is the definition of it. So,
I stumbled trying to get it out earlier. I
I
mean,
know, I
come on,
know,
people.
I know. Oh gosh, we're stuck with that. Oh yeah.
So
So
going
that
forward, we might just call it OMD,
let's do.
OMT. Okay.
Let's do
Yeah. Yeah.
OMDs. And yes, so that's what OMDs are. Do you want me to define something else too right now? Anything?
Um, I think, well, let's start there because my next question
Okay,
is how does this relate to us as school based? Oh, that might be deep doctor right there. A deeper question.
that's
Uh,
okay. I'm
but
ready.
where should we start? Should we start on like well, the definition is the patterns. Maybe
Right.
we would go to further define that. So actually let's do this. So sometimes I jump ahead and I'm going to stop
Okay,
myself
that's
and I'm
okay.
back up. So I like your definition that it's habits, conditions, and atypical patterns that can affect resting posture and also function. So oral motor at rest and oral motor at work. So that's the definition, but what are characteristics that we would be wanting to look for as
Right,
clinicians?
right. So especially, clinicians, especially in the schools too, you would want to look for if they have any oral habits that are going on, like thumb sucking, nail biting, that's going to affect the position of the tongue, because when they are sucking or just their tongue fingers resting in their mouth or nail biting affects the jaw, it affects the tongue.
I did not
Yes.
know that.
Yes. Anytime I have a nail biter, I have them, whether it's an adult or a child, I have them show me how they bite, and I will take a picture of that. And then also show them, because if you're biting like this, your jaw shifts and your tongue actually often goes to that position too. And so,
Wow.
and then as often as you're doing that, that's a resting posture that you're having too. You can have more than one, and that would be your nail biting or thumb sucking resting posture. Mouth breathing, like mouth breathing. And it matters if they're just mouth breathing some of the time. It's like I'll hear when I'm mentoring, I was like, well, their mouth is open some of the time. Well, that's just as important as if it's open all of the time, because we want to be habitually nasal breathing. So mouth breathing and the tongue posture. So we can talk about that. If the mouth is open to breathe, the tongue is going to be down. So that's you could see that. Also, the tongue posture. I was working with a kiddo, consulting with a kiddo yesterday, and he's 12, and his speech is impaired and unclear and distorted because of oral myofunctional disorder, OMDs, and his tongue floats in the mouth. It doesn't rest low in the mouth. It doesn't rest on the palate. It doesn't rest against the teeth. It's just floating in the middle of the mouth, sometimes on the teeth. So there's another thing about the posture. It can also be, even with the lips closed, the tongue can be floating in the middle of the mouth or pressing on the front and middle, the top and bottom front part of the teeth. So, yeah, so that's thinking about where does the tongue operate? And with him, we were talking about where is it operating? It was operating in the middle of his mouth, not vertical, but horizontally.
So, I mean, just off the cuff, I'm thinking like I could tell, like I could visually see if somebody is a thumbsucker.
Right.
I could see if they're a nail biter.
Correct.
I could definitely see with my eyes if they're an open mouth breather, if they're a mouth breather.
Right.
And then I could also see a low forward tongue carriage.
Correct.
But I'm not sure I could see a floating tongue.
No.
But we can I'm writing that down. We're gonna come back to
Yes.
that.
Yes,
Okay.
we should.
Because I'm gonna come back because I don't want to jump ahead before we get
to that.
we get there. But I definitely want to come back to how you can figure out that floating tongue. Okay.
Yes.
So common characteristics, did we cover them?
We also like poor oral control from like drooling.
Okay, thank you.
Past the ages that drooling is appropriate.
Mhm.
Immature chewing or eating skills. I'm not talking about feeding at this point, just the eating skills, the oral phase, and then speech production errors.
Okay.
And the tongue thrusting swallows.
That reverse swallow.
Yes. Yes, that. Yeah.
Okay.
So those are ones that you would be able to notice. And also inability to maintain lip closure, meaning so there's closing of the lips to breathe, right? And the mouth to breathe. But if the lips can't stay together, it's called lip incompetence, because they don't have enough tone or endurance to stay together, and they might just like fall open. And that can affect some of our speech sounds as well. So.
Well, I could totally imagine that you could get a bilabial at the syllable or word level, but when we're getting into conversational speach,
right,
that would be where it affects. I'm jumping ahead again.
Okay.
Sorry, everyone. Okay, I've added then, of course, the drooling, of course, yeah, secretion management past the age of where it would be typical, and we're looking at our and then immature chew pattern that of course resonates with me being a dysphagia support speech pathologist, looking at that possible, and of course speech production is what we're all about. That reverse swallow, inability to maintain lip closure. I like that. Lip competence. I like that wording.
Yes.
especially when we're writing our observational notes, when we are taking a look, when we're doing our oral mech
Yes.
at the child, we could be writing these things down.
Yes.
I always like when I get a good term that
Right.
really, like, I like less words that mean exactly what
More,
I want.
right, exactly.
Yeah.
And then did I say and mention the tongue restrictions or the tethered oral tissue?
No, I was gonna just ask if we're gonna talk about TOTS.
Yes,
Yeah.
yes, that is something. So the range of motion, the tongue range of motion issues.
Mhm.
So lateralizing or, yes, so that is also under the OMDs.
And I'm thinking also lip
Lip
restriction.
too, yes,
Yeah.
thank you, because I had a kiddo, he had lip, and so his P's and B's were sounded okay. Sometimes they were F, but sometimes they were, but there was no lip closure. So again, in conversation, it would really come show its head of the
Mhm.
difficulties he was having.
Sure, sure.
Mhm.
Yeah. All right. That's a long list, y'all, of characteristic. Now, is it safe to say that just because you see something, we don't automatically jump to OMD?
No, 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 no. And it's good to, as we know, it's good to write down these things that you see so that in the end, when you're putting it all together, because you can't know what you don't see. So if you
Exactly.
observe something, just put it down, and then you can use your wonderful clinical therapist brain and be like, okay, this fits under this, but it doesn't, fit in this hole, but it is something significant for something else. But yes, just I often say that and teach this in the assessment that, we as speech pathologists are trained to hear the sound, right?
Mm-hmm.
Sound. But I like to teach that you need to think of the assessment and screening as visual. Lots more of it is visual. Like, what do you see that's happening? Not only what you hear, but what do you see? Because that's
Mm-hmm.
very important.
Right.
Because
So
that helps you determine what to do. Excuse me. Yeah.
no, I'm trying to put that together in my brain because this is the new area, in some respects, not oral motor because of
Yes.
feeding with me, but I'm just thinking about that when we're talking about speech production, it's not just listening for the production of it, but looking at how they're producing it and writing these down,
Yes.
and how that could I know we're going to jump into how they impact sound. Well, maybe that's what we do next.
There we go.
Hey, look at that's a wonderful
We're right there.
segue. Let's, instead of me like just pussyfooting around, let's just jump into like, okay, we're doing our oral mech, we're doing our language sample, we're doing our assessment, and
Yeah.
we're starting to write down, and we're noticing these characteristics.
Yes.
Okay, what are so we kind of talked about the characteristics, the fundamentals. What are the impact of speech production?
Right. Right. So one of the pretty obvious ones that we would see is the tongue that's coming forward and doing interdental of sounds, specifically the S's and the Z's. Oftentimes that is, a part of it. And one thing before I start into the nitty gritty with the sounds, OMDs don't just distort individual sounds. It impacts the clarity, the rate, and the precision of connected speech. So these are the kiddos that maybe they can produce the sound in isolation or in the words, but you get them into connected speech, and it's like the clarity and the crispness is gone and you can't like quite figure it out. Well, it could be again where the tongue is coming from rest and where it's operating from. And once you can fix that and notice that, just like the kiddo I was talking with yesterday, I asked him to rest his tongue on the roof of his mouth, gently, no suction, but resting up there. And then I had him go into an S sound. That was the one and only clear and crisp S he made in the entire session, because I was mostly getting information from him. And towards the end, I asked him to do this and make that sound. And then I used that to encourage him to focus on the resting posture work at home because he could pair and see how it was actually going to be useful for his speech.
Heavy. Wow.
Right. Yeah, and this was a 12-year-old boy, and he was like, got it, excited. He said yes, and so the therapist working with him, they're going to come up with a plan of how to practice the rest posture, and then also use it each time she gets him to elicit the sound.
Because we're pairing that with tongue placement for sound production. I'm
Exactly.
connecting the dots,
Right.
connecting the dots here.
Right. It's such a simple
Is it?
task.
No, I'm being
Right.
cheeky now.
No, you're right. It is such a simple task to ask,
Mm-hmm.
but it is not a simple action or position to maintain
Sure.
or
Okay.
come from. It is
Right.
not, yeah, the concept, well, okay, when it's physically possible to elevate your tongue, okay, then they can, and then we have to, and I'm going to switch to like the oral motor piece here.
Okay.
That's like where you create awareness and you're going into like helping with the movement, oral motor, oral, I'm going to interject this, oral sensory motor, okay?
Mhm.
Oral sensory motor, and all motor is movement. So you can, at this point, it's simple to ask them to elevate their tongue, but can they keep it in that spot and then go into the S sound? This kiddo could, but not all of them can. And so maybe you have to stimulate the back of the back lateral edges of the tongue and say, okay, keep this, stabilize this, and then, let the air flow and then change the shape of the tongue and whatnot. So, but yeah, it's simple, but it's not.
Right. It sounds simple, but it is a lot of work,
Yes,
especially when you're trying to change a habit.
right. And it's a lot of work for the therapist and it's a lot of work for the kiddos. It is.
Absolutely. Yeah, sorry, I didn't mean to cut you off.
And just even getting to the ability to rest the tongue in that position is challenging for a lot of the kiddos.
So, I kind of think this is bringing us into when we talked before to talk about the difference between myofascial OMT, the treatment of, versus oral motor exercises.
Right.
Because
right,
I do
right.
know, yeah.
Yeah.
Can we
Okay. Yes. So oral motor OMD is all about function. So orofacial myofunctional therapy. So it's all about like breathing, swallowing, chewing. What did I miss? Resting. Okay. Because resting is resting, but it's not actually, because we're activating the tongue muscles when we're resting against the palate, because you have to like hold it up there. Not suction, but even just resting is kind of like, so function. So with the oral sensory motor, it's about creating awareness, helping with movement, stimulation, and like if they're overstimulated, you need to like calm the system down. And so, but they do go hand in hand to help with speech production. So
Tell me more.
yes.
Tell me more.
So here's the best example. So there's a strategy or something called the tongue bowl. And so it is where, okay, this is my, let me just use this. Okay, so here's my tongue kind of thing. All right, and this is even better. You can kind of see the tongue bowl, but that's my R. Anyway, okay, the tongue. And so to elicit this bowl where there's mid-tongue contraction and the lateral edges are elevated, say that's the goal, that you want to have a tongue bowl, because there are reasons. So there's a reason, which I'll get to. So you may be able to ask the kiddo, we'll make a tongue bowl. Okay, so they just did it. But if they can't, then you have to use an oral sensory motor strategy or technique, like go around the lateral edges of the tongue to stimulate the primitive reflex that creates the tongue, mid-tongue contraction. That is a oral sensory motor strategy. Also, putting a M&M in the middle gives them tactile feedback, or tapping in the middle. All of those are for oral sensory motor. The bowl, once you get that shape, you can have them elevate to the palate, and then you can use that for a tongue bowl swallow practice, or saliva gathering, where the saliva, you scoot it up on the sides and you then hold the tongue there to swallow, or to help with a tongue practice with tongue resting. So that's how it becomes functional, but you have to use oral sensory motor techniques to get to the movement. Then that turns, and then you also, with that tongue bowl, you can shape it into speech sounds.
Tell me more.
Okay, so since all of the consonant sounds are made with tongue contacting with the palate, okay, and a lot of them are made with needing lateral edges to be stabilized. A lot of the sounds need that. And so the tongue bowl shape helps to get the tongue into that position that you can teach it how to stabilize. And then, so you've got stability, then you can go into mobility for the speech production piece.
I love this. We got to get stability in order to get mobility.
Exactly.
Love it.
Exactly. Exactly.
So when we're, so what I think a lot of times we're like, so I guess what I want the cat out of the bag, or to be transparent, that we're not doing oral motor exercises for oral motor exercises purposes, but we're utilizing orosensory motor strategies in order to elicit tongue placement and function in order to produce the sounds.
Exactly. Exactly. It is always in my therapy sessions, I am with an articulation client, with a client that has speech due to OMDs. I am constantly doing the speech sounds and I am doing the OMD work at the same time. Whichever one I'm doing, like if they're stimulable, then we're using the rest tongue posture then to move into the sound, if that works. If it doesn't, you have to back up, just like we have to do in all our, but it is not something that you just do alone for speech sound production. No.
I think a lot of us want to hear that you're
Yes.
not saying that we would have a goal of doing an exercise. These are just treatment strategies
Exactly.
in order to elicit the sound, and that the target of your goal is, the target is the sound production.
Right.
And this is just another tool in our toolkit on getting the students to be able to elicit that sound.
Right.
And I like the point that you pointed out that most of our consonants need the lingual stabilization
and contact
with the palate in order
Right.
to, right?
Right.
Sure.
Right. They do. And if you talk about vowels, where this comes into play is that the vowels are very, very reliant upon the jaw and the function of the jaw. And so, like in the cases where you have a open mouth posture, their jaw grading is going to be affected. Same with when you have kids that are clenchers, and they may do that to keep the tongue from coming, out, with the S and the Z.
Yes.
That is a functional issue that needs to be addressed so that the speech sounds can be clear and crisp and accurate. So you would use a strategy to help stabilize the jaw in order for the tongue to be able to move and be stabilized, so it's not coming through and as in a S with a lisp or a forward moving tongue for an S.
Okay. All right. Thank you for clearing that up. Because I think that is important, that we're not saying
Yeah.
that we're going to be doing a goal for an exercise. Our goals are
Yeah.
still targeting the sound production.
Right. Absolutely. Absolutely. Always in my.
I know, I mean, I know you just gave us one strategy kind of for treatment, but can we back up a little bit and talk a little
Yeah.
bit more about assessment? And then we
Yeah.
can go back. Can we do assessment and then jump back into
Yeah.
treatment again?
Absolutely.
Okay, thanks.
All right. So specifically with assessment, it's important to watch the kiddos eat. Every assessment, every kid, watch them eat. Because you will find out a lot of information. I mean, it can be a cracker, it can be a piece of candy, whatever, because you can find out a lot of information about how the tongue moves and functions before you even, like, the operating area, where it wants to hang out, if it can lateralize or not, before you even ask them to do the speech sounds, or after you do that to add to it. There again, is just observing with your eyes, not only your ears, but adding your eyes into it. Always, like the oral mech and the oral function. I created a little, I think we've talked about, I created a screening form that I have given out to the schools about the tongue, the lips, and the jaw, how they rest and how they function. And it's a little screening that you can do with each kiddo that comes through. And it's a lot of visualizing and seeing, what is the jaw doing? Is it aligned? Is it not? What is the tongue doing? Where what are the lips doing? And so it's a great screening tool and a way just to look at more of the postures and the function.
And you shared that with me, and I want to make sure that that gets attached yes,
Yeah.
Paige, you were just asking about the
Yes.
screening tool. And yes, right before we got on today, we were talking about that, that I'm hoping I'm going to get a link before the end of today's episode that I can get into the chat. If not, afterwards, I just resent it to Speech Therapy PD, and we will make sure that it is attached to the show notes, because it is a great little screening tool. No one has time to reinvent the wheel.
Yeah.
So Tricia, thank you so much for sharing that. And we will make sure that it is available for our listeners for sure. So we love the screening tool. And I have to stop and say, I love the fact that you say watch them eat, because that's what I do all day, every day. And when all I do. And to me, doing an oral mech and seeing them do what they do without anything in their mouth does not tell me anything. And so watching a child eat really shows you so much of their function.
It does.
So I know, I think it's incredible. So I endorse that 100%.
Yay. And I also,
I just saw that, I think did someone say that they tried to open it and it was blank? Did I just see that?
yes, it's
gone now.
downloading blank for me on the website.
Okay. Oh, Jessica said it worked for her. So
Yay.
Megan, try it again and see if it will open up for you. Yay! I want to make sure everybody gets that.
Yay.
Yay. Okay, that makes us all very happy. Oh, yay,
Good.
Brianna.
Yeah, I'm seeing that
Okay.
too. Another thing while we're on assessments, I wanted to talk about, and so no matter what, and I'm old school, so I'm gonna say Goldman Fristo because that's
Yeah.
so, but whatever articulation standardized that you're using, test you're using, I like to have a little key that I add on to that, and I use like arrows that point, like do an S and then I'll do an arrow like that, and that shows me and tells me that that tongue was coming forward out of the mouth just right when I'm doing the sound assessment. And yeah, and so I made up this little
Okay.
key for myself. And then, like, so also I would put J for jaw, and then I would put a direction. Like if I noticed that the jaw was shifting to a certain side, then I would put J and push left, or J and push right, with the arrows too. And so I created, and this is all about the visual. And what I would recommend is that it's so simple now to video, and we have our
Yes.
phones, just video every opportunity for assessments with the eating and also with the articulation and in conversational speech. And don't forget to video them profile. because you can see things going on with the jaw if you look at them speaking in a profile as well.
I love this because I love anything that makes my life easier. I love that key, y'all. J for jaw, and then just an arrow for where the jaw is shifting to the left. So then you write that, because I think that writing all that down when you're trying to really suss out what's happening and being
Yes.
able to have shortcuts, that's perfect. Any other key shortcuts you can give us? It's great.
So yeah, and I can also send this to you because I have it. Because what I actually did was I took the phonetics of the words, right? And I had the words phonetically written down on a piece of paper. And then I had the opening for my observations on the side. And so I could do it on top, but I could also make a note like not crisp, but placement fine, but not crisp. Jaw was doing, and it was about what the jaw was doing, what the tongue was doing, and also about distortion.
Mm-hmm.
And just the big X if it was distorted. And I couldn't at that moment figure out what it was. And then dentalization, which is usually part of but I think it's important about what the tongue is doing and what the jaw is doing. So the tongue is coming forward or the jaw is going left or right. Yeah. So that's part of the one that I would use for the assessment. Video that, and then the
shorthand, the keystrokes, so that when you're really writing it out, you know what's happening. It's not just that it was a slushy S, that it was the tongue.
Incorrect. Yeah.
Right. Incorrect tongue placement, airflow. And if you,
Yes.
yeah, so we're getting, yes, please send your,
Okay. All
your
right.
cheat sheet,
Okay.
anything
And
that, yeah.
yeah, full disclosure is for the Goldman Fristo, but you can work it with any of the Arctics, right?
Absolutely. No, but
You
we could just
can.
get us started. So those of us
Exactly.
that, yeah.
Exactly. Yeah. 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 So,
Perfect. Okay. So looking at assessment, we've done our assessment. Maybe, yeah, we've done the Goldman. We've not only did we listen for the production, we're also looking for the function.
right.
And then we've written our notes on what's happening with the production and the function for the speech production. So then let's get into what would we do for treatment.
Right. And just make sure you've also in that looked at the resting postures of.
Oh, I jumped ahead.
Yes.
Okay.
And one thing I want to add too about that is even to the ages of 4 years old, I have asked kiddos, we were talking about the tongue floating, right? This is kind of
Yeah.
part of the assessment. I have asked little ones, what is your tongue touching? Or what is the tip of your tongue? I show them the tip of the tongue or whatever with anything that we have. And then I say, what is your tongue touching when you're not talking and you're not eating? Right now, what is your tongue touching? And they will tell you. They will say, it's not touching anything. Then that's the floating in the middle. It's touching my bottom teeth. It's touching the top. It's touching my top teeth. So asking that during your assessment is great to do. Also, ask them about what their jaw is doing. Like, are your teeth together or are they apart? And it'll be amazing how many times they will tell you that they're together, like they're clenching. And then that's a clue that you need to look into their jaw. Why are they clenching when they're sitting there?
And
It's
why
not,
would they be? Like, what
yeah,
are
right. Other than stress, right? Other than taking that piece aside, it could be this is an orofacial myofunctional disorder, is that clenching is what, so it could be under that, so it'd be a sign for that. And also it's just a point of like, if they don't have good grading of the jaw or stability, like they don't feel very stable, they might just be doing this. And the kids that kind of talk like this, and they say they're excellent. You need to look into the grading of the jaw. Why is it staying at that high instead of being able to go low? And where does it lose its stability maybe, or its ability to stay aligned? And that is going to affect intelligibility.
Yes. Yes.
Significantly, that jaw is a piece of that. So where the jaw resting,
So there I go again, always jumping ahead. So I'm going to back myself up with assessment because I was just about to jump on a treatment. So let's back up on the assessment. So we're doing our standardized test. We're doing our functional test or along with our standardized test, we are doing our um our key,
Yes.
our shorthand for
Yes, our
what
shorthand.
our shorthand for what we're seeing with the oral motor structures, what their function, how they're functioning or not functioning, how they're, for example, if jaw grating or groping or tongue is to the,
And all of that is on that screening form that they have.
that
Yes.
okay, perfect. And then what I really want to go back to, because I think that was the part I almost skipped over, the floating tongue that I had written down, is that it is important to also ask those awareness questions. Ask the students where their tongue is, and that might be a little lesson first of making sure that they know the speech machine.
Yes, right.
Right. Make sure that they
Yes.
have the language for teeth, gums, lips, tongue, cheeks.
Yeah. Yes. The
Mhm.
visuals and the language and everything so that they understand the question that you're asking. Exactly.
Sure.
Yeah.
Yeah.
You're right.
I mean, I could see it might be difficult with our children with limited language.
Absolutely.
However, you know what? Never underestimate a child. Always give them the benefit of the doubt. Give them the
Right.
language always.
Yes.
Exactly. Yeah.
Yes. Yes. And when we talk at the end about those visual aids, and storytelling, I have a point with that.
Okay. Okay.
Mhm.
All
Yes.
right. Shall we get into some treatment?
Okay, let's go.
Okay.
All right, so treatment. Literally, I get asked a lot about what exercises should I do if someone's asking about orofacial myofunctional therapy, right? What exercises should I do? And I am of the thought, I don't I don't even like or use the word exercises
Thank you. Neither do
at all.
we.
Yes, I don't, because and even in I'm writing a book with an orthodontist, and even in that book, I was talked to her about, it's like it's an activity that we're doing for a certain function. And so when you're learning about OMDs or when you're trying to learn about OMDs, it's really important to know that it's not just about going through these exercises and these exercises are going to be good for every kiddo, because it's not like that. That being said, the foundation of orofacial myofunctional therapy or disorders is in the resting postures of the tongue and the lips and the jaw. This foundational, that is the piece that is extremely important to speech sound production. So if you are learning about this and wanting to know what you can do to help your students, checking in and teaching them about the resting posture, and like the kiddo I was talking about, showing them how if your tongue is in this position against their elevated near your palate, you're going to be closer to or be able to produce that sound. Whereas before, when you were doing it, your tongue was coming up from the bottom and trying to get at the top. It's not efficient. That lag time is going to create distortion. And so it's like major bang for your buck and for the kids' bucks if you talk to them and show them that this is an activity, a strategy, a technique that's going to help them with their speech sound production. The resting posture is, because that helps with stability and operating from the right placement.
Which is one of the big things that we are working on. They
Yes.
need to know placement in order to produce. So
Right.
what do you suggest that we
To
use?
get there. So, to get to the placement piece,
Sure,
or the
yeah.
rest, yeah, placement. I suggest using any and every tool in your toolbox. Okay, anything you can have, anything that's able to fit in the mouth, anything that the kids can use in their mouth, tactile, visual, auditory, videoing them and showing it back to them and saying, what do you see? What is your tongue doing? What do you see is happening? Okay, then how can we change that? Talk about the tongue stabilizing and helping with that. And then if you have, even if there's some range of motion issues with the tongue, you can still work on and try to get that resting posture or the tongue to elevate at even like if it's the tip, it's not all the lateral edges, it's some of the tongue, because then it's still better, even if it's like, say, a kiddo's not going to be able to have the release done for some reason, or whether it's still better if the
An
tongue
approximation, a closer approximation, I think is
exactly.
what you're getting at, is that we can still work on getting a closer approximation for speech
Yes.
clarity.
Thank you for that word. Yes.
You're welcome.
That's one of those approximations. Yes, exactly.
Sure.
Exactly.
I would like, is it, can we talk about I was trying to get pictures of your book so I could put it in the chat. And for some reason I couldn't, they were coming up weird, like you couldn't open it. But I kind of want, do you mind just going through the names of your books? Because
Yes.
these are great for using, stories and using books in your therapy.
Right.
Having
Yes.
something already made would be great.
Right. And in therapy and also during assessment. So I'm going to talk about them both, but first
Okay.
of all, I will. So this is one of them. It's called Miss Tongue Learns to Rest. This was the first one that I started with. And what is really useful in this book is written for children. Okay, so this is one talking about how the tongue is tired and it's has all these jobs it has to do. It has to talk, it has to swallow, it has to eat, and it gets really tired. So one of the things for assessment, you can use the pictures in here to say, is your tongue resting on, is your Miss Tongue resting on the pillow? Or is she resting on the teeth? Whoops, there it is, right there. This is where she's resting on the teeth. Is she able, hold on. Is she able, this is in my Miss Tongue Learns to Dance. This is about tongue range of motion and or in preparation if a kiddo is going to have a lingual frenectomy done. But there is a great picture of Miss Tongue trying to do lingual palatal suction. Okay, so this could be utilized to try to say, this is what I want, your tongue to go to the top. Can you make your Miss Tongue do this? And, she's struggling. Oh my gosh, she's trying really hard to do it. Can you try really hard to do it? And then with the Mr. Nose Learns How to Breathe, when you're doing an assessment or you're practicing nasal breathing, you can have them read the book to themselves or you can read it with them, because if the kiddos can breathe through their mouth, there was a study that was done, breathe through their nose, for 3 minutes, then it's most likely it's a habitual mouth breathing and not a structural or.
Wait, I'm so sorry. Say
No.
that one more time.
So if the kiddos can breathe through their nose for 3 minutes, right? So you could be reading the books to them for this 3-minute period. Mr. Nose Learns to Breathe. If they can do it for 3 minutes, then it's most likely, this was in a study, a habitual mouth breathing issue, not a structural, meaning they cannot breathe through their nose. It's just a habit. Maybe they had an allergy and they got over the allergy, but the mouth is still open because it was used to that. So you can use this book to screen and make sure they can breathe through their nose before you teach nasal breathing, and use Mr. Nose while they're doing it. A therapist texted me that she had done this. And then there's another one, the lips learn to stay together. And this is all about teaching about lip closure. So you can use them in like, can you make your lips do this? And then you can also use it like in assessment, also use it when you're trying to teach about the importance of lip closure. Because all Miss Tongue, Mr. Nose, and the lips all learn about their job or their function and what they're supposed to do. And then in the end of the book or the other part, you get to, it's you go do a super challenge, and can you make your lips, your Miss Tongue and your Mr. Nose do its job or its function. So
I love it. And I just so you know, I popped in the chat. If you are interested in these books on how to get to your website on that. Do you mind if we take a question? We got a
no,
question in
yes,
here.
great.
So Jessica has a middle school student. She says, what if it appears as though their tongue is enlarged and achieving this resting tongue posture impacts airway function? I have referred to an ENT, which hasn't been done yet. However, can it be partly anatomical?
Great
And
question.
and if it is a structure anatomical, can it be remediated? What a great question, Jessica.
That is
Thank
a
you.
great question. This is Jessica. Yeah. Okay, so there is something called that where there is a large tongue. It's very, very rare, but there is something like that. What could possibly be happening in this situation with this middle schooler is, for one, the tonsils could be so huge that it's making the tongue come forward, and they have to do this to breathe because there's airway issues. It's also very common, and back to the tongue bowl, you might want to try the tongue bowl with this kiddo. It's very common for a tongue that is not resting on the palate because it's not getting that isometric exercise or feedback, right? And activating for it to have like low tone and look larger or too big for the mouth. So that is also, and so in those cases, like many times the parents were like, oh, well, the tongue's just too big for its mouth. Well, no, it was just not the coordination of the tongue and the I'm going to say this word, the tone of the tongue was just not there. And so you can actually, the toning of the tongue just happens with it learning to rest against the lingual palatal contact. So let me see, did I get everything of that? So great job to have done a referral to the ENT. Yes, if he's it could be like it's coming forward and it's too big because of the tissue in the mouth. I had a kiddo like that. And then also just the motor control and tone of the tongue. Is there any more to that, Jessica, that I didn't cover?
She says thank you.
Okay, good. Yay.
Oh wait, no, she did add more. Listen, he's
Okay.
had his tonsils removed. So at one point it might have been that.
Okay.
Am I wrong in saying that they can grow back?
I was going to say, if they haven't grown back, because yes, they can grow
Yeah.
back. Okay,
Oh,
they're
she's
not there.
checked. Okay, thanks, Jessica.
So he had tonsils that were okay, so they've been removed, so he doesn't have tonsils anymore. So I would,
But she says she's going to try the tongue bowl.
yeah, good. And hopefully that ENT, I am sure that ENT has checked the adenoids and all of that piece too. So, and can this kid nasal breathe, even though the
So
tonsils
do the
are-
3-minute nasal breathe test as well, Jessica.
Yes, yes. And that's from Dr. Zoggy.
Oh, that's what I wanted to ask for that. Can you, Zoggy, could you spell that and I will
Yes,
see if I can get that.
Zaghi, Dr.
Okay.
Zoggy out of California. It is difficult for him. I will try. Okay, nasal breathing is difficult. Okay, because he has been habitually breathing through his mouth, I would assume. But yeah, and feel free to reach out. I am on Facebook and Instagram. So Jessica, feel free to reach out to me and we can talk more about that because I love mentoring about things like this.
You gave me your email. Can I share that as well?
Sure.
Oh,
Yes.
okay. Let me put that in the, I'm going to
Yes.
put that in the note, in the chat, but Paige came in and has a question to talk about how to elicit that tongue bowl position. If you can, if you start on that, I'm going to
Okay.
get that. Yeah.
Okay, so tongue bowl. So you want to have them sit up really, really tall because that's going to help with just the whole alignment. It's going to help the tongue be able to do what we want it to do. So you would the best way that I start with is called the M&M tongue bowl activity. So because the kids and adults love this. So you have them sit really tall and you have them open their mouth and like, just like they're going to say, ah, okay. And then you have them place an M&M on their tongue. And if you can't do the M&M, you can just tap with a tongue depressor or the tooth at. But you have them put an M&M on their tongue, and then you have them smile because you want them to stabilize the jaw, so they get big smile.
I'm
And
doing it.
then, yeah, there you go. And then you have them lift the edges of the tongue to make like a candy bowl. Okay, and
Ooh,
then
I
you
love how the candy bowl with the M&M, y'all.
yes, yes, yes. And so then you just have them hold it for like 10 seconds, and then they get to eat the M&M. And then you repeat it for 6 times, and then you got like a whole minute work of the tongue bowl. And so don't be surprised if the M&M doesn't sometimes roll off the tongue, because that will happen. If they try, you don't want them to use their lips to hold the tongue in place. So that's why you have them smile. And you want the tongue to be not resting on their teeth either at all. It's a process to get the tongue bowl to be where they can hold this for 10 seconds. But and you can look up Pam Marshala
Okay.
has the tongue bowl reflex and the tongue bowl to talk about making a tongue bowl, eliciting it and making it. I did not make this up. That she's, a teacher and mentor of mine. So that is, look that up. And what else can I say about that? I have a way I judge this. I judge if they can keep their lips back. I judge that they can keep their jaw at stable. And I judge that the tongue is not curled back. You don't want the tongue to be flipped back like this. You want it to be where you can see the color of the M&M, because that means that you're getting all the lateral edges are lifting, and you do not want a taco tongue. You do not want a taco tongue. Taco tongue happens a lot if there's a very significant tether, but we don't do taco tongues.
No taco tongue, not
No
even on
taco tongue.
Tuesdays.
Yes, yes, exactly.
Hey,
Oh,
y'all, I also put in, thanks for the Pam Marshala. I just put in a link to that, and then I'm going to get the other one too.
great.
Hi, Stephen. My dog is now wanting to say hello, but I'm going to in a minute. I have a new partner. Okay, so sorry. I know we're coming to the end, but I want to make sure that we were going to touch on a little bit of like how to use some of this in like teletherapy. We still have a few minutes.
Yes,
So
yes. So my books are in ebook form, and it's I created them because people in the other countries are where I can't mail them to are buying the ebooks. But they're also so beneficial for telehealth because you can have them up on the screen and share them. And that's been I've gotten really good feedback about that. So try that out. And telehealth. It's hard whenever, like during the pandemic with all of my kiddos, I would send them a little kit that had the the tooth that's in it, and then tongue depressor and tongue popsicle sticks, because those are like your main helper, because you can't get in there and like show them what to do or tell them what to do or do it for them. But you can have them be able to stabilize their jaw so they think you can move the tongue. Those are the really good tools that I think, in addition to the ebooks, if you're going that route. And it's harder sometimes, but thank goodness for telehealth, because we're reaching people that we couldn't in kids before, and just get really close up in that camera and show them how to rest their tongue and their lips.
thank you. Yeah, you know what? Can we take another question before
Yes,
we end? Because Brianna, thank you so much. Do you think these strategies can still help or increase speech clarity for a child that has overall low muscle tone and a possible underlying syndrome? There is not a diagnosis of anything for this student that she's talking about, but the OT and myself have both seen this child for years, and we both suspect a genetic or a medical underlying issue. He can do most sounds and words, but his speech falls apart at the conversation level and definitely has lip incompetence and decreased range of motion and rate of tongue movement. Go.
Mhm. Yes. Okay. Yes, I think so. Talking about, and I'll tell you an example. You can cut me off when we have. I
Yeah,
had to do a consult with a kiddo that has a syndrome that was causing an open mouth, open bite, and no lip closure, and but very precious, sweet child. So I go in to work with her therapist and talk, and my books are laying out on the counter, and I can tell she's very uncomfortable for me being there with her therapist. And so I was like, oh, do you want to look at this book instead of like getting right into it? And she like picks up the Lips Learn to Stay Together. She picked up that one that she wanted first. And so she's reading it. And as she's reading it, her lips just started going together. And she maintained that. And she like saw my picture at the back of the book, the author, and she looks at me and she looked at, and she grabbed another book. And then she went to the Mr. Nose Learns to Breathe. And while she went through the Mr. Nose Learns to Breathe book, she kept her lips closed. And the therapist was like, I have not seen her do that in that much time during one of our sessions. So with this kiddo, if there's I think the visual aid with the books, and I created these books for my clients, and then just the pandemic happened, and I'm like, okay, here's what I'm going to do. And so I created them into real books, right? I created the concepts. And so it helps, I think, too. And yes, with this kiddo, try the resting tongue, try the lips together. And if you can get the lips closed, then the tongue's going to be closer to being at least to approximating. And so start with the lips. It's very visual, it's very easy. And good luck with that. And reach out to me.
Thank you. So I added your email. I also added Dr. Zaghi's 3-minute nasal breathing test.
Great,
Thank
great.
you. I know
Good
we
for
are
you.
at the end. Thank you so much, Tricia. This has been amazing. This has been absolutely so helpful. And I know that those of us that are listening are going to be able to go and immediately use what some of these strategies and what you've told us in our practice. I love that. I want to thank you so much for coming.
Oh,
I am
thank
so
you
glad,
for
and I can't wait
having
to
me.
collaborate more with you.
I know, I'm looking forward to that.
Yeah, me too. I want to thank everyone for listening today. I love this. Those that are listening, if you've enjoyed this episode, please be sure to give us a like, leave us a review, share it with your fellow SLPs. I really hope I see everybody in our next episode. All right, guys. Bye. Bye, everyone. Thank you so much. Thanks for joining us on today's podcast. Remember to go to speechtherapypd.com to learn more about earning ASHA CEUs. We appreciate your positive reviews and support and would love for you to write a quick review and subscribe. If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Hope to see you on our next episode. Also, please don't hesitate to tell us which topics you would like us to cover in future episodes. To get in touch, drop us a line in the comment section or send us a message on social media.